Okay, okay. But can you possibly turn on a mic for Anastasia? She joined us, but she can't speak.
Полина будет выступать, можно и несколько микрофонов. Если мы...
Я могу вообще ставить.
Не, садись. Почему не первый? Надо что-то просто Вы как-то это? Или мы поздно? Есть? Так, мы начнем с нас. Не, ну у вас хотя бы написано, а я уже только 10 минут назад сказала, что это сейчас. У нас связь есть очень удобно. Эффект неожиданности. Просто пытается понять.
Okay, so we can start with our clinical case, if not against.
Да, можно. Только не открытие возможно. Да.
Видимо, не слышно.
Знаю.
Так, минут по 10, не больше, да?
Я за 5 вложусь.
Я еще не готовилась, поэтому ем за 3. Да, все, кто не готовился, вопросы. Задают вопросы. Слушайте.
Colleagues, can you hear us? We're ready to start.
Yes, we can hear you well. And then
Okay.
And we've made Mrs. Anastasia as co-host of the meeting. So
Thank you so much. Can you now hear me?
Yes.
Hello, dear colleagues. We are glad to see you today. Thank you for connecting us again. There are lots of doctors also from our side for today. As we discussed last time, we have not only the radiotherapy department, but also our chemotherapists and pathologists to discuss our clinical cases for today. And we prepared for you although 3 cases from different departments, which I already told you. So if you're ready, we can start, because I think today's conference will be very interesting, and we will have a lot of cases to discuss with you. Are you ready?
Yes, we are ready. So before starting out today meeting, I would like to introduce from Ho Chi Minh City Oncology Hospital. This is Dr. Bao. He's the deputy head of the general radiation oncology department. And this is Dr. Tang. She will present. She will share some cases, and there are also students from University of Medicine and Pharmacy who are studying oncology. They will join with us in person at the meeting room, and as well as online in the Zoom. So I think now we can start, and then I would like to invite you to share your cases first, and then after that we will have discussion. Thank you very much.
Okay, thank you very much. So with us also today is Dr. Tatiana Sharabura. You already know her. We are discussing clinical cases with her and her department for a few times already. And also we have today here Fedor Moisenko. He is the head of the chemotherapy department, and he is also online with us today, as he's ill, unfortunately.
Hello, my friends. Hello, glad to see you and hear you.
Oh, we don't see you.
Fedor is hiding from us. Okay, so we can start, please, Tatiana Mikhailovna, with your presentation.
Dear friends, dear colleagues, very nice to see you again. And today we would like to discuss the treatment of soft tissue sarcomas. Here, our radiotherapist Polina. We invite our colleagues, pathologist Alexei and chemotherapist Artyom. Retroperitoneal sarcomas are very rare tumors, and the long, due to the long asymptomatic period, they often reach the high size, and it's the problem both for the surgical and the radiotherapy treatment. In the great retrospective study, including nearly 10,000 patients with retroperitoneal sarcomas, the combination of radiotherapy with surgery prolonged the survival, and the preoperative radiotherapy was more effective. But in the well-known European phase 3 randomized trial, the efficacy of neoadjuvant radiotherapy was not confirmed. The relapse-free survival wasn't improved in comparison with surgery alone. Only for patients with liposarcoma histology, the local control was higher with neoadjuvant radiotherapy. So, unlike the extremity sarcomas, the efficacy of radiotherapy for retroperitoneal sarcomas is not established. Besides, there is the higher risk of complications with postoperative radiation, as intestine is moved to the bed of the removed tumor. With the preoperative radiation, the tumor displaced the intestine, and when the risk of relapses is high, neoadjuvant radiotherapy is preferred. But what can we do when the tumor is too large? Different ways to solve this problem are known. One of them, to reduce the dose to the whole large tumor and to elevate the dose to the high risk margin. The width of this margin is nearly 1.5 centimeter, and it is near the lateral. It is adjacent to the lateral and posterior wall of the abdomen, to the paravertebral space, aorta, and another great vessels. Intensity modulated radiotherapy with simultaneous integrated boost provide the delivery of elevated dose to this high risk margin. It is better to define this high risk area together with the surgeon. In phase 1 trial, the neoadjuvant image guided intensity modulated proton radiotherapy provide the elevated dose to the area of high risk, to the margin of high risk, with simultaneous integrated boost, and the very high local control was achieved. So our radiotherapist Polina will introduce you 2 clinical cases. I must say that for target volumes delineation, we follow the ASTRA guidelines. Polina, please.
Hello, dear colleagues. I would like to introduce you some cases from our center. First, it's patient A. It's female, 60 years old. It's August 2022. She sees some increased volume of her abdomen and turned to the physician. Initial follow-up, you could see on the slides, it was 3-zone CT, and it was giant multinode tumor, more than 2,000 millimeters. In this slide, you can see how it was. And the next step was biopsy based ultrasound control and histological examination. It was in our center. On the slide, you can see gene and histological tests. And it was dedifferentiated liposarcoma diagnosed in this patient. And then we discussed this patient in DT, and the first step was surgical treatment. It was a complex surgery with nephrectomy and colon resection because of invasion in these organs. It was at the October of 2022. Then she had some follow-up, and after 1 year, we can say at July 2023, as you can see, she had local recurrence. Here we can see this local recurrence in the same place that first tumor was. And then we start treatment of this patient in September, and now this patient in treatment. We discuss and choose neoadjuvant radiotherapy and BMAT technique. Regime you can see on the slide. It's was with sometimes integrated boost for the part that you can see on the left side of the slide. Diagnosed says that it's some questions with invasion in muscles in this area, and here we increase dose. And on the right side, you can see dose distribution and criteria to organ at risk. As you can see, we meet all our criteria. In this case, tumor is near bowel and sigmoid, but all criteria are good for these organs. And the next case, it's patient male, 74 years old. He was diagnosed peritoneal liposarcoma, C4. And next we do biopsy to this patient, and the conclusion was spinal cell sarcoma, high grade. Initial follow-up includes 3-zone CT, and it was large tumor 2. And with extraorgan multi-node formation, and in this case, in kidney, left kidney was invaded with this tumor. For this patient, we choose neoadjuvant radiotherapy 2 in the same regimen as we discussed. You can see on the right slide the large volume of this tumor. We discussed this patient with surgeries and choose the area where it's so hard to eliminate this tumor. And these sites you can see as boost at this slide. And we should save right kidney because surgeries said that left kidney, it was nephrectomy for this patient. And as you could see, right kidney at organ at risk clinical goals, mean dose for these organs was 4 grays. It was an MRT technique because of hard and large volume, and in this technique we have better dose for organ at risk. The next step with this patient was surgical treatment with endoscopic removal of this large tumor. You can see in the slides it was more than 30 centimeters. Post-operative histology you can see on the slides, and we see many space of necrosis of these tumors. It says about our radiotherapy good effect to these tumors. And you discuss some pathology questions with our pathologist later.
Thank you, Polina. And just now, our pathologist Alexey will discuss them and tell us about the problems of morphology diagnosis of these tumors.
Thank you very much. The retroperitoneal tumors are not so often, and it's the main differential diagnosis include two parts. This should be excluded: solid neoplastic and non-neoplastic lesions, and cystic neoplastic and non-neoplastic lesions. Among neoplastic solid lesions, the most often we expect that it should be liposarcomas with subtypes well-differentiated liposarcomas or dedifferentiated liposarcomas. Other variants of liposarcomas are quite rare in this region, and is probably should be excluded the metastasis from the other sides. For example, if we may see myxoid liposarcoma in retroperitoneum is quite rare, and other type of liposarcomas. With some rarities, also should exclude leiomyosarcomas and some neural-related lesions and germ cell tumors. But the most often is liposarcomas in retroperitoneum. And in presented cases of this 74-year-old male, the large lesions, about 23 centimeters, which was attached to left kidney and colon, distended colon, and was treated with radiotherapy. We performed for verification of diagnosis immunohistochemical staining with MDM2. A microscopic view of this tumor, you may see here a great volume is proposed by solid nodule, and this is the standard colon you may see here, and here is a left kidney. On cut section, you may appreciate that most of the tumor after neoadjuvant therapy was provided by necrotic tissues with this yellowish gray color, and only at the rim of preserved tumor you may see here. Microscopic, you may see the different parts of the tumor from well-differentiated part to more cellular, high-aggressive regions. At high magnification, a lot of pleomorphic cells with multinucleated and with some inclusions, and some you may see also the lipoblasts here, to which support the diagnosis of liposarcoma, as also probably here also. And also in the stroma, a lot of inflammatory cells and macrophages as a result of neoadjuvant treatment. And this is the region of necrosis, of cell type necrosis with abrupt transition to viable tumor. And this is immunostaining for MDM2. You may see a very intense expression of these markers, which support diagnosis of dedifferentiated liposarcoma. We didn't perform here cytohybridization because the location of the tumor and the classic morphology and these positive markers also. But the final report was dedifferentiated liposarcoma with 23 centimeters in greater dimension. This grading in for with a French system is not applicable here due to treatment of the tumor. Margins were negative for tumor and was positive for MDM2, and the pathological staging after treatment was T4. And a few words about the evaluation of response after neoadjuvant treatment. We need to say it's no agreement between with different organizations in the world. You may see in the left column the recommendation of CAP, the latest version, and they propose to evaluate the quantity of tumor necrosis. And the European Association of Sarcomas proposed to establish the evaluated proportion of viable tumor cells, not necrosis. And the latest version of international cancer reporting is they decided to combine all these approaches and provide clinicians information about percent of viable tumor, percent of necrosis, percent of therapy-induced change among not necrosis such as fibrosis and ankylosis of the tumor, and percent of maintained differentiated area of the tumor. In our clinic, we made a mapping of the tumor after treatment, as soft tissues, sarcomas, and its bone sarcomas. Then we evaluate the percent of necrosis and fibrosis as a marker of post-therapeutic change. Evaluate status of margins and provide a stage of the tumor.
Thank you. And we would like to introduce you one more case of the retroperitoneal sarcoma with a metastasis, and our chemotherapist, Tom, will introduce this case.
Thank you. Good morning, dear colleagues. I'd like to introduce you a clinical case of stage 4 retroperitoneal sarcoma. First of all, it's a 59 years old patient, first complaining of increased abdominal volume with pain syndrome in December 2019. CT examination showed us that there was a large tumor in the right side of the abdominal cavity, and as well as metastasis in the lungs. First of all, we did biopsy, and the biopsy results revealed spindle pleomorphic cell tumor. Do pathologist to comment this? Or should I go on?
Ну, это вообще ваш слайд. Я не вставляла сюда, слушайте, я сюда влез. Извиняюсь. So,
yes, you may appreciate the microscopic view of this lesion. It consists of fascicles of spindle cells, and they arrange in an angle each to each other. And in high magnification, the nuclei of the cells are very monotonous, and it's not had such pleomorphism as is the previous case with the differentiated liposarcoma. And also you may see here a lot of mitotic figures. This and this and this, and no signs of lipoblasts here, and also the areas of necrosis. Immunostaining, and this is the areas of fibrosis also, because it is after treatment change. Immunohistochemistry revealed soft tissue markers such as desmin and smooth muscle actin, and it was negative with MDM2, and you may see on slide control with positive MDM2. So the final diagnosis was leiomyosarcoma of retroperitoneum. This grading here also was not applicable due to the treatment, and positive immunomarkers, desmin and smooth muscle actin. And the staging also D4 due to large dimension of the tumor.
Okay. Let's move on from this case a little bit and discuss the role of chemotherapy treatment of soft tissue sarcomas. The role of drug treatment of soft tissue sarcomas is uncertain, to be honest. There are no large studies investigating the tactic of drug treatment. So the recommendations are based mainly on studies that have been performed for all soft tissue sarcomas. If we are discussing local stages of the disease, surgical treatment will be the main method of cure. However, neoadjuvant treatment, as we can see, may be considered in some cases. The main goal of chemotherapy is to shrink the tumor volume for subsequent surgical radiation treatments. Which chemotherapy regimen should we choose? To answer this question, we have ICG-STS study, which will help us to make a decision. There were two arms in this clinical trial. The first arm was the standard chemotherapy regimen for all histological types of sarcomas, and this regimen was anthracycline-based chemotherapy. And the second arm utilized histology-tailored chemotherapy. It means that for every histological type, investigators chose different chemotherapy regimens. And after chemotherapy, patients undergo surgery with or without radiation therapy. As we can see, the results, according to the results of the study, it appears that the standard regimen was superior to the histology-tailored approach. If we discuss non-resectable sarcomas, there's also no one-size-fits-all approach. As a guideline, even suggests that we consider observation of asymptomatic and indolent tumors. Regarding chemotherapy regimen, there were number of studies of different chemotherapy drugs. Sorry for this mess of information, but there are all the regimen which we can use basically to treat different types of sarcomas. But as we can see, progression-free survival was almost approximately 6 months in every study. So there is no domination of one regimen. Okay, let's return to our clinical case. We finally found this tumor mass in right side of the abdominal cavity. We can see this on these slides. Metastasis in the lungs also persist. We did biopsy, and our pathologists discussed this. So we started our treatment with anthracycline-based regimen. We performed 6 cycles of this treatment, and the result of the treatment was stable disease. We ended our treatment in November 2020. As we can see, we analyzed metastasis in the lungs and primary tumor. But after nearly 4 months after the end of the treatment, the progression of the disease was registered in the form of increasing the size of the primary tumor, also increased the size of metastasis in the lungs also increased. And metastasis in the bones appeared. Due to compression of the right ureter, an ureteral stent was placed on the right ureter, and a course of pain control radiation was conducted due to the pain syndrome. After this event, we used second line of therapy. It was eribulin. And after 2 cycles of therapy, we also registered a progressive disease. And we moved on due to symptoms of the disease in the form of pain syndrome. We moved on to and decided to remove the primary tumor. See this the increased size of the tumor on this slide. So, video endoscopic removal of retroperitoneal tumor was performed. Histologic and histochemical report told us that it corresponds to leiomyosarcoma. Taking into account the necessity of recovery after surgical treatment, the patient's management tactics was chosen as observation. Observation was during 10 months, and after 10 months, the progression of the disease was detected at the next CT scan. The progression of the disease was increased in size and appearance of new metastasis in the lungs, and also appearance of metastasis in the liver. The third line of treatment, you can see this on the slides. Third line of treatment was chosen as Gemtax regimen, and patient during this treatment we registered a lot of adverse events such as neutropenia, grade 4, thrombocytopenia, grade 3 with hemorrhagic syndrome, and also anemia. And after 2 cycles of the treatment, disease progression was also recorded, and the treatment was changed to monochemotherapy with etoposide. And it was a miracle that patient started this treatment in September 2022, and the treatment is going on till the present days, with no serious adverse events. As a response to this treatment was stable disease. Summarizing this clinical case, we can say the drug treatment of sarcomas in most cases is ineffective, and the therapy can be the effect of therapy is really unpredictable because, as we can see, standard aggressive regimens did not give us any positive effect, but monochemotherapy with etoposide prolonged its life for this patient for 1 year. But in this case, it's unclear what exactly allowed to prolong the patient's life, whether it was due to drug treatment or debulking. Thank you.
Thank you. So the treatment of patients with sarcomas and retroperitoneal sarcomas need the efforts of a multidisciplinary team, and sometimes the treatment of protocol will bring a success. Maybe you have and introduce your own experience. And I would like to show you St. Petersburg. It is beautiful at any season, and especially at autumn. Thank you. Maybe you have any question?
Dear colleagues, we thank Dr. Shirabura and all the doctors for the presentation. So we'd like to ask if you have any questions or comments on our case.
So thank you very much for your very interesting presentation. And now our physicians will have some questions for these presented cases.
Thank you for your presentation. So I would like to ask one question about neoadjuvant radiotherapy for retroperitoneum sarcoma. As you show us that you would do 36 grade 20 fraction and SIB for GTV boost up to 40 grade 20 fraction. In some guidelines, they recommend the dose of 50 grade 25 fraction. So I would like to ask you, how come you choose the dose for your patients? Is it because of the bowel toxicity?
Thank you. Of course, I must tell at the beginning that for liposarcoma, the liposarcoma is a radiosensitive tumor, and there are some trials have showed that the reduction of the dose to 36 grays is enough. Gray is enough to reach the same effect as 50 gray. As this was liposarcoma, we reduced the dose, and as we have seen in the pathomorphology result of the radiation, the high morphology pathomorphology was reached, so this dose was enough. But if there is another morphology, then we think that to reduce the toxicity to the intestine, we can reduce the dose to the whole tumor and to deliver the more high doses to the high risk margin. In the case of liposarcoma, we don't need this escalation more than 40 gray, but for another morphology, we'll do it. It isn't necessary to deliver the high dose to the whole tumor. As the recurrence located at the bed of the tumor, this area must receive the elevated dose, but not the whole tumor. If it is the risk of complications from the intestine. I have answered your question.
Well,
dear colleagues,
well, at our center, we haven't ever tried to do a pre-op radiation for retroperitoneum sarcoma. So actually, we don't have any experience about that. Is 50 gray feasible for abdomen tumor like that? Have you ever do any case that with a total dose up to 50 grays?
No, our experience is not very large, and liposarcoma is most common, and so we don't have another sarcomas. But the dose to the whole tumor will depend on the tolerant dose to the intestine. And in Russia, there are some centers that have the experience of delivering escalated dose only to the high risk margin, but not to the whole tumor. I think that when the tumor is very large, the delivery of the dose 50 gray is difficult and the risk of complications is high.
I understand. At our center, patients keep coming back because of recurrence, and we just do the operation again and again until they cannot.
Yes, we also do it. Thank you.
I have one more question about the CT mutilation. Do you use 4D for this type of disease? 4D CT in simulation?
Excuse me, I don't understand. Once more, please.
So you do the simulation with 4D CT or 3D CT?
No, it was not for 4D CT, it was simulation CT. The tumor is so large, it wasn't necessary to control the breath, I think. But we can do it, and when the tumor is located in the upper abdomen, then we, of course, use 4D CT.
Thank you so much.
Thank you.
So today,
colleagues, have you got any more questions, or we will proceed with your case?
Yeah, I may proceed to my presentation.
Please go forward.
Yeah. Today I will present about radiation in sarcoma at our center. So soft tissue sarcoma is a broad term for heterogeneous group of rare malignancy arising from connective tissue. It can from a fat tissue, muscle, or vascular and peripheral neural tissue. It invades longitudinally along muscular aponeurotic planes, rarely spread to lymph nodes, and the most frequent sign of distant metastasis is lung. It can occur anywhere in the body, extremities, trunk, or retroperitoneum, rarely from head and neck and thorax. Because of the rarity of this disease, and with more than 50 histology, so optimal management of this disease requires a multi-modality team as a specialized center with oncology, surgeon, medical oncologist, radiation oncologist, pathologist, and radiologist. Besides that, we also the team should have a orthopedic surgeon, reconstructive surgeon, social worker, or physical therapist. An appropriate surgical resection is a curative treatment for sarcoma, especially from extremity sarcoma. While resection combined with radiotherapy is current standard of care for most sarcoma, the role of chemo is unclear except for rhabdomyosarcoma and Ewing sarcoma. So radiotherapy had mostly in 3 indications for post-op, operative, pre-op operative, and palliative radiotherapy. Pros and cons for choosing post-op radiotherapy and pre-op radiotherapy. For GTV definition, with pre-op radiation, we can see clearly the tumor based on clinical and MR imaging. So the PTV smaller than in case of post-op radiation, and the total dose with number of fractions is lower. However, in pre-op radiation, the problem is the wall healing may have complication after the surgery. So at my hospital, the radiation machine system has been improved over the years. Before 2005, we only used Cobalt machine, Cobalt 60 machines with 2D simulator. And the conventional radiotherapy, we treat extensively from the scar after the surgery. Gradually, we progressed to 3D CRT, IMRT techniques over 10 years with contribution of improving immobilization, IGRT, and medical physicists training. So from 2018 to now, we use CT and MRI for diagnosis before treatment. 3 2-beam machines added, the IGRT with CBCT, OSMS system integrated inside treatment room. Right now, we can choose between 3D CRT and IMRT technique depending on tumor size, location, and treatment indication. Now, we can capable of irradiating big tumors or some or tumors next to critical structures. Right now, in our facility is equipped with 3 GE-CT simulator, 3 2-beam, 1 trilogy, 4 Clinac machines, and 5 other electron machines. We have 3 machines with 6 degrees of free table and 3 machines with 4 degrees of free table. 6 machines with CBCT and 4 machines with OSMS system. In our department, for over 2 years, for 2 recent years, from June 2021 until now, we have about 450 patients with diagnosis with sarcoma admitted to our department. Over more than 10,000 patients. It accounts for 4.5% of total patients, and among them, nearly about 300 out of 450 have received post-operative radiation. 40% of the treatment is used IMRT technique. We have just started the pre-operative radiotherapy for extremity sarcoma in 2 years, and until now we have done with 20 patients. 13 patients receive IMRT and 7 patients receive 3D CRT. Now I would like to present 2 cases. The first one is pre-operative thigh sarcoma, and the second one is a case of recurrent fibromatosis of the back. Female patient, 44 years old, have admitted because of the painless mass in the left thigh in July 2023. She was led the biopsy with the result a monophasic synovial sarcoma. No nodal involvement or metastasis. In the MR imaging, it demonstrates a lesion with in the vastus intermedius muscle of the upper left thigh, attraction to femoral neurovascular bundle, with a size by 7 by 6 centimeter, with high signal intensity on T2 and post-gadolinium construct enhancement, and the necrosis inside. So the imaging of the thigh. She was diagnosed upper left thigh sarcoma T2 and 0 M0 stage 3A, and at that time not favorable for surgery. And she was proceeded with pre-operative radiation with total dose up to 50 gray, 25 fraction. And she was planned to have the surgery after treatment course 6 weeks, 4 to 6 weeks. With the GTV, we define the GTV by images on MRI, and the CTV is GTV plus 1.5 axially and 4 centimeter longitudinally, except the natural barriers. And PTV was were margin from the CTV and 0.5 centimeter. We use 7 fields with the beam angle at 50 degree, 20 degree, 350 degree, 320 degree, 250 degree, and 220 degree, and 190 degree, in order to avoid the opposite leg skin flash 1 centimeter outside the body. Most of the dose constraints are acceptable. Here is the GTV, CTV, and PTV. Some of the beam view, for the beam view example, and the dose distribution with the DVH. So the problem is we monitor the treatment using CBCT. In the first 2 weeks, the inflammatory tumor made the changes in shape of GTV and PTV. So I have to use steroids during the treatment course. And after that, in week 4, in the last 2 weeks, the swelling was decreased. So you can see at the day 1 and middle of the week 1 and week 2, the tumor is increased in size. So this is from the last week of the treatment course. Next to the second case, a female patient. She has a medical history of HIV treatment over 20 years and a diagnosis of fibromatosis of the back. And she was received a wide resection in 2021. At this time, she admitted because of the recurrent mass in the back. She presented with a fixed rigid mass in the right back, 6 centimeter, and MR imaging can see infiltrative lesions in the erector spinal muscle, serratus anterior muscle, and intercostal muscles in the right back. The size was 7 by 7 by 3 centimeter, with low signal intensity on T1, high signal intensity on T2, and surroundings with satellite lesions. This is the tumor of the back. So she received a second surgery. In the record, the surgeon can see a 12 centimeter tumor invading muscle under the old scar, and the rib number 10, 11, and 12 in the right. So they decide to resect all the tumor, including the rib, including the invasion rib. The pathology was still fibromatosis, and the margins were clear. So she was diagnosed with recurrent fibromatosis of the right back post-op 1 month. And she was proceeded with post-op radiation to the total dose up to 50 grays, 25 fractions due to the dose limit to spinal cord. She was set in the prone position in a vacuum bag. The CTV 50 was margined from the operation bed, plus 1.5 axially and 4 centimeter longitudinally, including the area of the tissue chain size, tissue around the cut ribs. PTV was CTV plus 5 millimeter. And we plan to monitor her using OSMS. This is the contouring of this patient. And she still have on blending. The physicist still working on her plan. So I would like to ask some question about sarcoma, especially extremity sarcoma. For preoperative radiotherapy, so the tumor would increase size due to inflammation, along with the treatment course. Do you have any experience to resolve this problem? Do we have to resume the patient or do another treatment plan? And we have just treated 20 patients with pre-op radiation. One of them has progression to lung metastasis, and about 10 patients, I can't remember, already do the surgery after the treatment course, and while healing, it seemed fine. I already asked the surgeon, and he said that all of them have no complication about healing. So do you have any experience about that? Would you prefer IMRT or 3D CRT technique for pre-operation radiosarcoma? And another question about the second case, fibromatosis radiation indication. Thank you so much for your listening.
Thank you for the very interesting presentation. I must say that the problems you have shown are common and well known also for us. I must say that most of our patients today received post-operative irradiation, but the number of patients with preoperative irradiation is increasing. Our surgeons don't like to operate after irradiation as the risk of post-operative complications are higher. It's well known. But there are the advantage of preoperative irradiation. You have shown it. I don't have the one answer for the problem of inflammation during the preoperative irradiation. It's not common, I must say, and of course we use also steroids. I would like to ask you, I want to ask you whether you use stereotactic irradiation for preoperative, neoadjuvantly for the primary tumor, or you use stereotactic irradiation only for metastasis.
Can you repeat the question? I can get it.
You have shown us that you use sometimes stereotactic irradiation for patients with the soft tissue sarcomas. Do you use it for metastasis or also for the primary tumor? Stereotactic irradiation.
You mean stereotactic?
Yes. For what use it? For what circumstances? When you use it? For metastasis? And do you have the experience of the stereotactic irradiation of the primary tumor? Primary sarcoma.
At our center, we do not use stereotactic for primary sarcoma. Right now, we only use the stereotactic for metastasis disease at metastasis site, like brain met or lung met.
Thank you. Of course, we also, but there are some trials where hypofractionation irradiation to reduce the duration of treatment is used for the primary tumor for preoperative irradiation. Что я хотела сказать еще? Что-то.
You mean you do hypofraction for pre-op radiation?
No, we don't use hypofractionation for preoperative radiation, but I think that it is the question of discussion, and as there are some trials with successful use of hypofractionation, I think that we'll do it, maybe not just now, but we'll examine it also. And how do you fixate the patients with extremity sarcomas? Fixate, what type of fixation do you use? Mobilization, fixation, immobilization.
Immobilization devices we use.
Thank you.
We use vacuum bag or mask for hand and feet. Sometimes, mostly we use vacuum bag.
And is it usual to irradiate the retroperitoneal sarcomas preoperatively? Do you use neoadjuvant irradiation of retroperitoneal sarcomas?
Can you repeat the question slowly? I can get it.
In our presentation, I delivered the information about preoperative irradiation of the retroperitoneal sarcomas. Do you use the preoperative irradiation for this type of sarcomas? Okay, I think that you use. You have previously, and we have one more question.
Hello, dear colleagues. Thank you for your presentation. It was so interesting. And I have one question about first clinical case. Why did you choose CT or not chemo for neoadjuvant treatment for this patient? Because patient have some stage and local disease, and we can use in this time chemotherapy for neoadjuvant.
Извините, мы только что с вами говорили, что надо много их получать операционно, причем.
Because this was a synovial sarcoma, and we know that is a sensitive tumor for chemotherapy. So this is my question.
Я думаю, что они не поняли. Вы поняли? I don't agree with you.
Я думаю, придется повторить вопрос еще раз.
А вопрос в том, значит, почему они не использовали химиотерапию? Но это также вот тут дискуссия между нами даже завязалась. Мы считаем, радиотерапевтов, что тут надо облучать предоперационно, а вот химиотерапевт предложил бы химиотерапию неадъювантно.
Хотя бы рассмотреть.
May I ask you a question? Our colleagues, our two doctors are asking you whether you will do the chemotherapy for this case or it's better to do radiation, because also our doctors are arguing between each other what is better in this kind of patient, to do the neoadjuvant chemotherapy or to radiate this patient. What do you think about this case?
For the first case, you mean the synovial sarcoma?
Yes. This case number 1. Yes, about yes.
I get it. So she present with unfavorable for surgery sarcoma, and at that time, with stage 3, we just decide between pre-op radiation or neoadjuvant chemo. And we choose pre-op radiation first, and we think if it doesn't respond to, if it will not respond to the radiation, we may use chemo after that, and along with the treatment, the tumor seem decrease size, and right now I transfer her to the surgery department.
Okay, thank you. And can I ask you again, how often, or do you have in your practice radiotherapy plus chemo together with doxorubicin, for example, or not? Did you do that? Ну что я так поговорю?
Radiation, может сказать.
Colleagues, did you get the question?
I must say that I agree with you. Our radiotherapist is agree with you. The preoperative irradiation is preferred, and we don't use chemo irradiation. It's very toxic for preoperative irradiation. Maybe for definitive irradiation for some cases, but not for this. Но это мы по-русски обсудим.
Хорошо, я готова.
One more question. The last question. Нет?
No, I don't have. Thank you.
Про фиброматоз.
У меня Алексей Сергеевич ответил.
Thank you. There are no any question, Anastasia. The very interesting presentation. The lot of problems to discuss. Есть еще случаи?
Да, если можно, или время, еще 2 случая.
Где?
У нас So we do have another clinical cases.
Colleagues, may I tell also our chemotherapists would like to show you 2 more cases on this topic. I think we will be shortly because we are going out of time. Можно вас попросить только достаточно коротко, хорошо, потому что времени у нас осталось не очень много.
Я сказала. Ctrl-L. Ctrl-L нарисовала. Куда? Не знаю. Мне сказали, что Ctrl-L и не Alt-L. Почему это не работает?
Так нет, а там же можно...
Сейчас может нажать. Можно? Сюда? Попробуйте так.
So hello again, dear colleagues. I am a medical oncologist from a chemotherapy department, and I want to present you 2 clinical cases about systemic therapy for a patient with soft tissue sarcoma. So first of all, clinical case number 1, it's a young man with normal medical history, just chronic gastritis. So this patient didn't have some symptoms, and it was just a chance find on a CT scan, tumor of soft tissues of the anterior chest. So he didn't feel this neoplasm. After that was the first stage. It was a surgical step in non-specialized medical center, and this surgical step was not clear. And after that, operation was without morphological verification, and after surgical step, we have this pathological result. So it's a low-grade fibromyxoid sarcoma and have a specific immunohistochemistry marker is MUC4, was positive. So after that, from September 2022 to March 2023, this was just observation. And next, on the CT scan, we saw pleuritis and multinodular recurrence. So the patient had 3 thoracic stents, and we every time did cytological report plus cell block, but didn't find tumor cells, just reactive pleuritis. So you can see this on the slide. We discussed this patient with a lot of doctors from St. Petersburg and Moscow, and we started 2 cycles standard chemotherapy, doxorubicin plus ifosfamide, but overall response was a progressive disease after 2 cycles. You can see this on the slide. After that, we thought that only one chance he had, and this is a surgical step. And this summer was absolutely incredible surgical treatment. Double thoracotomy, decortication of the right lung, total pleurectomy, resection of the diaphragm and pericardium, and hemoperfusion of the right pleural cavity, cisplatin. So you can see on this slide one stage of this surgical treatment. It's visceral pleura. And I have 2 questions for discussion for this clinical case. That's why, because we don't know what can we do in the future. And first question, what do you do after surgical treatment? Yes, right now patient is free. And next question, what to do as the disease will progress? I have this question because we know that low-grade fibromyxoid sarcoma is a super rare tumor and absolutely not sensitive for chemo and target therapy too. And I want to present you next clinical case. It's a patient, 56 years old. From June 2022, he started lymphadenopathy of the right inguinal lymph nodes and increased temperature. So first of all was a biopsy, and we have one diagnosis is epithelioid hemangioendothelioma. It was another medical oncological center. After that, patient came to us, and this is an immunohistochemical study in another medical center. It's a primary tumor from lymph node, no soft tissue, and in other center, first step was surgical treatment. And our pathologist give us another diagnosis, and it's да, как сказать? Да, как сказать? And next diagnosis is sarcomatoid carcinoma in our center. So that is why a patient has progressive disease after surgical and surgical step, and we started standard chemo, doxorubicin and ifosfamide. We did 2 cycles, but disease progression again. Next step was surgical treatment again, and this diagnosis is in our center is sarcomatoid carcinoma. You can see immunohistochemical study here. But patient смотрел гистологический материал, так сказать.
Second opinion.
Oh.
Second opinion.
Yeah, and but another center give us a second opinion that it's undifferentiated pleomorphic soft tissue sarcoma. So that's why we have 3 diagnoses. But but we thought a lot about this case, and we find it very high PDL expression, CP score about 100%. And that is why, because patient had the progressive disease this time, we started second line therapy, nivolumab. And you can see the result. It's a complete response right now. Thank you for your attention. If you have a question, or if you want to give us some opinion about first case or second, please, yes.
Анастасия, мы завершили.
Sorry, can you turn on the mic again for Anastasia, please?
Мы с ней обговорили то, что как мы сейчас завершим, поэтому хотела бы, чтобы она включилась. Да, она в курсе.
Я сказала, что вы тему обсудите отдельно.
Да, просто должна сказать. Thank you. Do you have any question? If not, then thank you for your attention. The discussion was very interesting, I think, and the next meeting we'll discuss later.
Well,
we can invite you to St. Petersburg.
Well, we are here just on a radiation oncologist, so we have no experience about chemo. 2 cases.
Sorry, but we think that you will invite a chemotherapist.
Yeah. So I would like to have one more question. Last one. Do you prefer chemo for what kind of histology specifically?
Okay, thank you for your question. It's a great question. Yes, we prefer to use chemotherapy for liposarcoma, but I know that it's radio sensitive too. Yes, synovial sarcoma, rhabdomyosarcoma, Ewing sarcoma, of course, and exactly, we try to use the chemo in every time.
Fibromatosis, no?
Yes, sometimes target therapy is useful for aggressive fibromatosis. I am a chemotherapist. I am a medical oncologist. That is why I prefer chemo. Yes,
all types of
a lot of types. Yes. Thank you.
Thank you for your answer.
Кто-то у нас завершит.
So I guess we finished our discussion, right?
Yes. In case you don't have any more questions, I think we have just finished the discussion part, and then. So In conclusions, thank you very much for your presentations as well as your cases. And I think we have had very fruitful discussions about how we treat patients in each institutions. And then after more than 1 hour, 1 hour and a half, and we've passed. So yeah, thank you very much for your participation today, and then we will see each other next times. And the subjects, do you have any suggestions for the subject of the next meeting?
Next meeting we'll discuss later, but I think that it's better to invite a chemotherapist for our meetings. As it is very interesting, as we have seen today. Yeah. And we'll discuss, we have some ideas about next meeting, but we'll discuss it later. Okay?
Yeah, thank you very much. Yeah.
Thank you.
Thank you.
Thank you, ma'am.
Bye.
Thank you. Bye. And see you again soon.
Recording stopped.